Welcome to AETCM, the emergency medicine channel. Today, as a part of EM Rapid, we are going to discuss about life-threatening chest injuries. So, life-threatening chest injuries comprises of tension pneumothorax, open pneumothorax, massive hemothorax, and cardiac tamponade and traumatic cardiac arrest. So in this part, the cardiac tamponade and traumatic cardiac arrest comes in circulation part, whereas tension pneumothorax and open pneumothorax comes in breathing part. Airway obstruction and tracheobronchial injury are also life-threatening injuries, which are part of chest, not a part of chest injury as such, but life-threatening injuries. So there are also other chest injuries which are not a life-threatening case, but we can also have to check about these things in the secondary survey, like simple pneumothorax, hemothorax, flail chest, pulmonary contusion, blunt chest injuries, traumatic aortic disruption, traumatic diaphragmatic injury, and blunt esophageal rupture. So in this session, we are going to discuss about life-threatening chest injuries. So first we'll come to tension pneumothorax. So tension pneumothorax, as the name suggests, here there will be one-way valve. Air will be moving into the pleural space from either the lung or the chest wall. So mostly the thing here, the air will be forced into the pleural space, and this will cause the collapse of the lung on the same side, and it will cause the displacement of the mediastinum to the opposite side, which will also compress the opposite lung as well as the uh, it will cause the decrease in the venous return. So it will cause the obstruction of the uh, venous return IVC, whereas that will cause obstruction, which will in turn cause reduction of the cardiac output. So this can cause obstructive shock. So the main clinical feature of tension pneumothorax is that it can cause hypotension. So other than that, the patient might have chest pain, air hunger, tachypnea, respiratory distress, tachycardia, and the tracheal deviation will be away from the side of the injury. So also the patient's neck vein can be distended to the mediastinal shift, and also there will be unilateral absence of sound when we auscultate the patient. So cyanosis can be seen, but as a late manifestation of the same complaint. So the causes are usually by a chest injury, a penetrating or blunt chest trauma, or else by a post-depressor ventilation, which can cause the rupture of the bulla. So it can also be due to iatrogenic causes, like if you are doing some subclavian or internal jugular vein catheter insertion, or else it can be caused by the thoracic spine fracture also. So very rarely, if at all, in cases of open pneumothorax, if we close the wall open pneumothorax on the four sides, it can bring about an open pneumothorax, can bring about a tension pneumothorax. The main signs of tension pneumothorax is that there will be hyper resonant note heard on percussion, and also there will be deviated trachea, distended neck veins, there will be absence of breath sounds on the affected side, and there will be patient will be having hypoxia desaturation, and the EFAST will show stratosphere sign or the barcode sign. Usually we will get a seashore sign where will be pleural changes, but here due to the pneumothorax we will get the stratosphere sign, as you can see in the picture provided. So the treatment is that there will be immediate, we have to immediate needle thoracotomy, costomy has to be done. So that will reduce the tension there. So we will insert a large bore needle into the fifth intercostal space, and which is slightly anterior to the mid axillary line at a depth of 5 to 8 centimeter. And if at all not possible, we will go about with the finger thoracostomy, and followed by, these are the initial management, it will be followed by tube thoracostomy after the needle or finger thoracostomy. So the main steps in needle thoracostomy is that you will use a 14 to 16 gauge needle in case of adult, and in 20 to 22 gauge needle in children and neonates. So the site will be fifth intercostal space mid-axillary line in adults and can be used in second intercostal space in mid-clavicular line in children and also in the fifth intercostal space. So here we use the needle with the catheter which are connected to a syringe and 5 or 10 ml with the saline taken. We'll inject the whole thing up to the in the fifth intercostal space, and we will get air bubbles in the syringe, and we will then connect it to the IV set to the bottle with sterile water below the line of the insertion, so that the it will not have the fluid from the bottle coming into the pleural space. So tube thoracostomy is the permanent method for the permanent management. So here you'll have to take in the sterile precautions like the gloves, mask, gown, etc. And followed by we'll have to do the tube thoracostomy with the 18 to 14 French for pneumothorax, whereas you have to go for larger French, 24 to 32 French for hemothorax, as there will be clots there. So patient, this is a painful procedure, so sedation is must. So you can use benzodiazepines for sedation, and initially we'll have to clean the whole area up with chlorhexidine, and give a local anesthetic like 1% lignocaine 4 to 5 mg per kg with epinephrine, and 5 to 7 mg per kg without the epinephrine. So we'll insert the tube in the fourth or fifth intercostal space in the anterior axillary line or mid axillary line. So here the tube is inserted in the between the fourth and fifth intercostal space near to the lower rib. So we'll initially we'll put an incision here, a 2 to 3 centimeter incision, and through the incision we'll insert a clamp, and we'll open and close the clamp so that we'll make a tunnel through the intercostal space, and this subcutaneous tunnel will be towards the pleura, and a rapid sudden decrease in the pressure means that the pleura is punctured, and we'll have to insert the index finger through the tunnel we have created, and following which we'll have to insert the trocar, and followed by we'll have to insert the tube, and after that we'll clamp and confirm that the tube is in the thoracic cavity by observing the condensation within the tube with the breathing, and also by the air bubbles coming into the wall mask bag which is having the bottle which is having the fluid in it, and also by confirmation with the chest x-ray. So the next life-threatening chest injury is open pneumothorax. Open pneumothorax is a large sucking chest wound. So large chest injury which will cause there will be large amount of air will be coming outside from outside towards the chest. So it will be sucking the whole air inside towards the chest, and usually the air is will follow the least path of resistance. Oh, here the signs and symptoms are the pain. The patient will be having pain and difficulty in breathing. Patient also will be having tachypnea, decreased breath sounds on the affected signs side, and patient will have a noisy movement of air through the wall of injury. As the air will be moving through the site of injury, it will cause a noisy movement of the air. So here the treatment is initially we have to close the site of injury so that patient won't be able to take in more air through the port of injury. So here we will close the valve with a plastic wrap or petroleum gauze, and we will close it on three sides, and one side will be kept as open, so that when patient is breathing during inspiration the valve will get closed, and during expiration the valve will the one side will which is open, through that open side the air can go out, which in then reduce the whole air in the lung, means the pleural space. So if at all we are closing the wall four sides, we can it can result in tension pneumothorax as explained earlier, and the definitive management includes we have to place a chest tube at a site remote from the site of the wound, and also subsequent surgical closure of the wound for or else it can have again go into another pneumothorax. So the next life-threatening chest injury is massive hemothorax, wherein with there will be accumulation of blood in the chest. So here massive means that the blood will be more than 1.5 liters. Here the most common cause is a penetrating wound that disrupt the main large vessels of large vessels or the hilar vessels of the chest. And here the neck veins can be flat or distended. Here neck veins can be flat in hypovolemia and can be distended in case of tension pneumothorax, or if the mediastinal, there is a mediastinal shift which can cause the distension of the neck veins. Here initially due to the hemothorax there will be hypovolemia, and this will cause there will be reduction in the preload and cardiac output, and there will be, due to the collapsed lung there will be hypoxia and ventilation perfusion mismatch. Signs are that the main signs in here are that there will be absence of breath sounds, and due to the blood in the thoracic region there will be dullness during the percussion, whereas we have seen that there will be a resonant note during percussion in the pneumothorax. Here the treatment is that initially you have to the patient has lost lot of volume due to the hemothorax, so we have to restore it by establishing IV lines and infusing crystalloid and blood transfusion as soon as possible. So during this time you have to call up the surgeons, and also uh, we have to decompress the chest cavity. Here the blood from the chest tube can be collected, and this can be given to the patient itself with the otra transfusion, and the chest tube here we use this 28 to 32 French inserted usually in the fifth intercostal space just anterior to the mid axillary line. And if if at all the blood volume is greater than 1500 ml, 1.5 liter, it indicates urgent requirement for urgent thoracotomy. And also there are other indications for urgent thoracotomy if the total volume loss is less than 1.5 liter, but the it is continuing to bleed to like a more than 200 ml per hour for the next 2 to 4 hours, then it is a indication for urgent thoracotomy. So patient need persistent need for the blood transfusion is also an indication for thoracotomy. And usually the penetrating anterior chest wounds is medial to the penetrating chest wound medial to the nipple and medial to the scapula, which can cause injury to the vessels, great vessels of the chest region, that can cause in turn cause a cardiac tamponade also. So we can differentiate between the tension pneumothorax and massive hemothorax based on various signs. So in breath sounds, in tension pneumothorax, the breath sounds will be absent or decrease, whereas in hemothorax it will be usually a decrease. And in percussion, resonant note is heard on hemothorax, whereas dull note is heard on hemothorax. In tracheal deviation will be like the deviation will be more deviated in pneumothorax, whereas mild deviation or midline deviation can be seen in hemothoraxes. And neck vein will be distended in pneumothorax, whereas it will be collapsed or can be distended in hemothorax. And chest movements will be decreased in both conditions. So the next life-threatening chest injury is cardiac tamponade. So cardiac tamponade is the compression of the heart by the accumulation of the fluid in the pericardial sac. So this will in turn result in the decreased cardiac output, and most common causes is that the penetrating chest injuries and blunt chest injuries. So this will cause the bleeding of blood from heart or the vessels to the pericardial sac. So the patient can have some of the clinical features which are most commonly called as Beck's triad, whereas the patient on examination there will be muffled heart sounds, hypotension, and distended veins. And we can also see pulsus paradoxus, whereas the when during inspiration the systolic pressure will drop by more than 10 mmHg. And tension pneumothorax is the most common differential for the cardiac tamponade, and we can usually see the cardiac tamponade live with the help of EFAST. And here the treatment is that the definitive treatment is that thoracotomy, sternotomy. If at all there will be there is difficulty during that procedure immediately during that time we can give IV fluids to raise the patient's IV venous pressure and thereby improving the cardiac output. If surgical intervention is not possible at that point of time, we can do pericardiocentesis also. So pericardiocentesis, we have to. There are multiple sites through which we can do pericardiocentesis. When subcostal pericardiocentesis is used, we use a large needle, large bone needle uh, for the same and aspirate blood from the pericardial sacs. So a large amount of fluid is not pulled out during at a single pericardiocentesis, as it can cause pulmonary edema. So the main steps in pericardiocentesis is that the patient is usually positioned at 30 to 45-degree angle with patient given adequate sedation and analgesia with 1 to 2% lignocaine. Usually, and patient site will be cleaned with chlorhexidine. And the most common site of pericardiocentesis is subcostal, and other sites are parasternal and apical. Apical and parasternal can cause injuries to the internal mammary, and also in apical there will be can injury to the ventricles also. So here the needle, we will introduce the needle slowly to through the subcostal area towards the left shoulder, like that. So during this time, when we reach the pericardium, we can have some increased resistance and a pop sound if at all we are through the pericardium. And during this time patient can have experienced like acute sharp pain, and we have to stop the advancement of the needle once the during this time we will be continuing with the aspiration, and we have to stop advancing the needle once the fluid is freely aspirated. So that at that time we have to stabilize it there and drain with the help of three-way. And like I already said, that if at all we are draining large amount of fluid, it can cause complication like pulmonary edema. The other life-threatening complication is traumatic cardiac arrest. Whereas when there is a cardiac arrest occurring due to trauma, the patient can have like without pulse, including PF, VF4 asystole. The patient can have here hypoxia, pneumothorax, profound hypovolemia, and cardiac herniation and severe myocardial contusions. This will cause the cardiac arrest. So there are very less chance of survival in this condition, and more than 10% survival is not in cases of resuscitative thoracostomy. Here the management is that we have to start CPR according to the ACLS protocol, and we have to give the epinephrine and the airway, also shock if at all there is a VT or VF. And definitely airway have to be you have to secure definitely airway, and find the cause for the same the trauma, and find the cause, like you have to perform EFAST. And if at all any chances of the fluid is there, thoracostomy or pericardioccentesis can be done. And during this time itself we have to continue monitoring the cardiac monitor, and O2 should be given. And according to the availability of the surgical team, if at all needed, we can do the thoracostomy also. So life-threatening injuries of the chest has been over. So there in airway part itself we can have life-threatening injuries. The first one is that airway obstruction. Airway obstruction, the main cause for the airway obstruction is like maybe some aspiration of blood or vomitus, or like a laryngeal injury, which in turn can cause airway obstruction, and the compression of the airway by the dislocation of the clavicular head, or the penetrating trauma of the neck or chest. Here the main signs you have to look is that there will be air hunger. That means that there will be muscle retraction, chest retraction, intercostal, supraclavicular retractions can be noted. And look for any signs of any obstruction like foreign body obstructions, striders, and in case of traumatic asphyxia we can see subconjunctival hemorrhage, petechiae, facial edema, cyanosis of the head, neck and upper extremities. And for other than that we can feel the crepitus over the anterior of the neck in cases of this condition. So here the management is that temporary we have to clear the blood or vomitus, as there can be aspiration. Because of that have to clear the blood or vomitus from the airway by suctioning. And the definitive management is that intubation and ventilation of the patient. So and other thing is that if at all there, this occur due to the dislocation or of the clavicle, we can palpate for the defect in the sternoclavicular joint and reduce the dislocation or the fracture of the clavicle. The next life-threatening injury in the airway part is the tracheobronchial injury. Usually the tracheobronchial injury, bronchial tree injury occurs within 2.5 centimeter of the carina, and main mechanism is the blunt trauma, urine rapid deceleration, and blast injuries or penetrating trauma. Here the clinical features is a patient can have hemoptysis and cervical subcutaneous emphysema. The tension pneumothorax or cyanosis also can occur. Here, this is the high chance of mortality is there in tracheobronchial tree injury. This is occurring due to the inadequate airway, development of tension pneumothorax or tension pneumopericardium. Here we have to look for the any change in breathing pattern and palpate areas of tenderness to look for any crepitus or defects, and auscultate for the air entry. And you have to look for the signs like increased respiratory rate or change in alteration of breathing pattern like progressive shallow respiration. And patient can have cyanosis, which is usually seen as a late sign. Here the management is that it will be difficult for the intubation to occur as the patient is having tracheobronchial injury. So if at all you are gonna do the advanced airway, it can be done with the fiber optically assisted intubation, and intubation of the unaffected bronchus can be done. So incomplete expansion of the lung and continued air leak after placement of test tube usually suggests like tracheobronchial tree injury, and placement of more than one tube may be necessary for the getting overcome the air leak. And can be confirmed with the bronchoscopy. And if tracheobronchial injury is suspected, immediate consultation of the surgery team and operation might be needed. So these are the main topics you have to see in cases of traumatic life-threatening chest injuries. So these are open large massive hemothorax, cardiac tamponade, and tension pneumothorax, open pneumothorax, and also tracheobronchial tree injury and airway obstruction. Thank you.